for bronchial carcinoid tumours, the atypical carcinoids and typical carcinoid tumours, interestingly, there's no set pattern of therapy. There's no specific therapy guidelines. The guidelines are less clear, if you like, than for the gastric and pancreatic intestinal neuroendocrine tumours. Obviously, if the patient can undergo surgery, that's number one, and with a view to hopefully curing the patient. It's important that the patient has had the appropriate workup in terms of the gallium octreotide PET scan or octreotide scan, as well as CT imaging, because you want to be able to identify where the tumours are, and that will have an impact in terms of the management. And the thing about the bronchial carcinoid or atypical and typical carcinoid tumours is that they can more commonly spread to bones without either the patient realising it or the physician, which may not be picked up on standard CT scans. The gallium octreotide PET scan is very good at identifying that, and I guess that's the biggest change I've seen in the management of patients with the advent of the gallium octreotide PET scan, is we're picking up more in the way of bone lesions, which might not have been picked up for years. And so patients shouldn't be overly worried about that, even if they are picked up, because we can have treatments which are good for that. But it's important to understand all of that information, because that will help our management. So what are the treatment options then if you have got residual disease that can't be removed by surgery? If the gallium octreotide PET scan or the indium octreotide scan is positive and the tumour is thought to be relatively slow growing, then we would usually put patients on a somatostatin analogue. The most common monthly injections are the octreotide or sandostatin LAR, or lanreotide autogel. The other name is somatostatin autogel. So many patients would start off on those once monthly injections first of all. More recently licensed is a drug called everolimus. Everolimus blocks some of the enzymes which causes the tumours to grow. And that's a tablet which one takes daily. And for those tumours which are growing, usually having grown through being on the once monthly somatostatin analogue, the octreotide or lanreotide injections, then patients may progress to everolimus therapy. And that's been licensed in the last couple of years, specifically for the bronchial or pulmonary, as it can be called, carcinoid tumours. The other options we have are related to if the gallium octreotide PET scan or the indium octreotide scan light up as hotspots, we can change the dye from the gallium octreotide PET to a stronger radioactive particle called lutetium-177, which is attached to the octreotide. And so you have lutetium-177 octreotide therapy, which goes to those hotspots from the PET scan, so it lights up where the tumours were lighting up as hotspots. You've got the lutetium-177 octreotide goes to those tumour cells, and you can kill tumour cells specifically that way. And certainly for patients, particularly who have bone spread, but also if they've got advanced disease in lymph nodes or liver, this is a good treatment. There's not still the clinical randomized trials showing definite proof as compared to the gastrointestinal neuroendocrine tumours. But there are lots of phase 2 studies which have been performed in many centres within our own centre and around the world, which have shown good benefit and good results with this therapy. The other option would be occasionally some patients might have interferon therapy. Interferon stimulates the immune system to fight tumour cells, but not many patients will get interferon therapy these days, usually because of the side effects related to temperature, muscle aches, flu-like symptoms, which can have an impact on the quality of life. But occasionally one might use interferon therapy. Chemotherapy can be very effective in patients with bronchial carcinoid, atypical and typical carcinoid tumours if the tumours are growing rapidly. And no one's quite sure of what the best chemotherapy choices are. And they can include chemotherapy drugs, such as ones called temozolomide, and that's often used in combination with other chemotherapy oral agents such as capecitabine. But you could have intravenous drugs. Sometimes streptozicin is used, which is traditionally used in pancreatic neuroendocrine tumours, but that can be used in combination with 5-FU or other chemotherapy agents in the lungs. And often patients with much more rapidly growing disease will undergo standard lung cancer type of chemotherapy, such as etoposide and cisplatin or carboplatin, and that can be effective in treating patients with the more aggressive tumours. There are also other newer treatments coming through, and so the topical one is immunotherapy, and you have new immunotherapy targeted type treatments. And interestingly, in the clinical trials, the early data suggests actually the atypical carcinoid group, but it was only a proportion of those patients, around about 20 to 30% of patients, benefited from immunotherapy treatment. You can investigate this a little bit more by doing some tests on the biopsy, and that will show whether there's a predisposition to perhaps being responsive to immunotherapy agents. I think this will be growing over the coming years, and possibly in combination with other therapies as well. Occasionally we use radiotherapy if there's a very localized lesion, and radiotherapy can be very effective for treating bone lesions as well, particularly if the bone lesions are causing pain. There'll be other clinical trials that patients will be asked to be involved with, and it's important to ask whether or not there are any clinical trials, because there's new developments in the area all the time. And there will be some new exciting drugs that I would predict coming through in the next couple of years. And therefore, you always want to ask, should I or can I be involved in any clinical trial if it's appropriate to me? A very topical question is Lutathera or lutetium-177 octreotide available for patients with lung neuroendocrine tumours? And if the patient's got a gallium octreotide PET scan, which lights up the tumours, then you would say that lutetium therapy would be a very good treatment. And there are a number of phase 2 clinical trials, but not the randomized phase 3 clinical trials showing benefit. But from our own experience and from multiple phase 2 trials from all around the world, particularly in Europe, there's been definite benefit in patients who've received the lutetium-177 therapy. So we have the problem in the UK at the moment that it's not approved by NICE. And how does one address that? I think what one does is by encouraging the pharmaceutical companies who are involved in producing it to conduct appropriate clinical trials and to be able to recruit as many patients as possible to those trials. And I think the patients themselves actually should be canvassing actually even pharmaceutical companies who are involved to be running those clinical trials, but actually also their healthcare providers within the NHS to say this is an important drug. It's been shown to work in the phase 2 studies. There are limited options in atypical and typical carcinoid when they're advanced, and it's a good treatment and a well-tolerated treatment, and therefore it really should be made available to patients with lung neuroendocrine tumours, and so that we can get more information about any side effects related to it, but also to prove that it works. And I think everyone has a role, from the physician who would want their patient to have it, but also the patient in campaigning to make sure that the clinical trials and the treatment is made available. Following up, lung neuroendocrine neoplasm can be controversial. There's no specific guidelines out there. And again, it will depend on the biology of the tumour, whether it's a typical bronchial carcinoid or an atypical, the more aggressive form of bronchial carcinoid. If the patient has had surgery, whether or not all the tumour's been removed, and also whether or not lymph nodes were involved. If a patient has atypical bronchial carcinoid and it's involved the lymph nodes, then all patients should be followed lifelong, even if it meant initially 6-month imaging, but going after a period of time with no obvious recurrence to annual imaging, patients should be followed lifelong. And that's because patients can have recurrence of disease many years later. For a typical bronchial carcinoid, the much lower grade type of bronchial neuroendocrine neoplasm, actually, if there was no evidence of lymph node involvement, if it was a neoplasm of less than 2 centimeters in size, you might argue that after 5 years, it's not unreasonable to stop the follow-up. However, in that scenario, if there were ever any new symptoms, then you need to go back to your doctor and certainly at least have an X-ray and usually a CT scan to assess the lungs. The basis of the follow-up, which you should be discussing with your doctor, is the size of the tumour, whether any lymph nodes were involved, ideally whether or not a gallium oxygenate PET scan was performed before the surgery, which might be useful in following up longer term, and the biology of the tumour, for example, in the Ki-67 proliferation index, because the higher the grade of tumour, the more active the tumour, the more frequent the follow-up is required. And so it's not a one-size-fits-all. It's very much dependent on you, the individual, and the type of surgery you've had and the staging of your disease, and your doctor should be able to discuss with you the rationale, therefore, for the follow-up in that scenario.